So at this point, I'm going to bring back my friend and colleague, Dr. Nooka, and we're going to have a little bit of a chat about, and we've talked a little bit about this already, which is great, but a little bit of a chat about myeloma research in African Americans. And, we've hit a few highlights already today, Ajay, which is that maybe most importantly is that more work needs to be done. We need to understand this, right? As doctors, we need to sort of come to diagnosis before we can come to treatment. On the other hand, when we use the word research and African Americans or Black patients, there's a tremendous hesitancy, and appropriately so, because sadly of the history of some awful things that have been done over the last many, many years. And so I want us to, a little bit in our chat today, to explain what we mean when we talk about research and how we're trying to understand this condition better, understand what the condition is like in African Americans so we can have better outcomes for them, that no one is trying to test anybody out of their will, or no one is trying to expose people to things that could be dangerous to them. We want the best. I think Brandon said it really well in our earlier interview, Ajay, when he said, don't complicate things. Let's really, find a way to sit down with people face to face and show to them that we have their best interest at heart. So with that background, Ajay, tell me a little bit about the work that you and the team do at Emory. I mean, I really have been impressed at how much you have done in this area, and maybe you could just tell us from a high level a little bit about it and what's motivating you to do this.
Thanks, Joe, for the opportunity to talk about what we specifically do at Emory. So in the bigger picture, so Emory is located, I'll give you the demographic that we serve and where exactly the problem is and what we've done as a solution. So Atlanta and surrounding areas in Georgia has close to 35% African American patient population. So our clinics clearly reflect the same exact numbers, so 35% to 40% African American patient population. So when we look at the clinical trial enrollments across the country, so just the numbers that I previously talked about, 5% clinical trial enrollments across the country is not, I would say, either there was lack of understanding, lack of awareness about the real need for a patient to be in the clinical trial. And now when we look at in the Emory structure, we see around 35% of our African American patients getting out of the clinical trials. So there was a uniform representation of what the demographic that we serve. So we started to look at where exactly we have succeeded compared to the other places where we have not been as successful. So there is a inherent understanding that we should serve the demographic that we represent or where we are, and that has taken over from the leadership across the board. So that is the biggest challenge that we see at the other institutions, which has never been a problem. Sharice is on the advisory boards for the executive leadership, so that has made our work very, very easier in terms of these the leadership buy-ins. So now I'll drop down into the different aspects of where exactly we have gone in and the specific African American projects that we've done. So we have a good COE program, the community outreach program that really goes into understanding. And coming to the specifically for the myeloma populations, we have the tissue acquisition programs. So understanding what happens in MGUS in African Americans. So Madhav Dadapkar, one of our colleagues that we hired from Yale, has a specific interest in this aspect. So he ran a trial called the SWOG trial, where there were 330 patients that were enrolled on the SWOG trial, of which around 17 to 18% were African American. And what he tried to establish was try to see what is the rate of transformation among African Americans compared to the Caucasians. So there is a very low risk of transformation. It is almost 5% over a 24-month compared to 15% among these patients that enrolled in the SWOG trial. And they were able to get those samples for these patients over an 8-year period. So we have continued the same here at Emory. And when we reach a patient asking them, hey, we want to understand more about what is happening with the African-American patient population, the rejection rates that we have are almost less than 5%. So that is purely from, this is not research, this is not a drug that we're using, but this is purely coming in from a sample acquisition.
I think that part is really important, that one of the things we want to emphasize throughout this whole program is that we build trust and confidence with individuals, that we want the best at heart for them. And I think that's partly what hopefully you're building in that community, is to be able to say, we're here, research not to test people like guinea pigs, but to bring to them an opportunity to learn more so that things can be better. When I think of, I think you said it nicely in your talk, when people hear clinical trials, they think about so many different things, Ajay. And I just really want to clarify this point, that a lot of the clinical trials we do are drugs that have gone through a lot of testing already and are very close to getting approved by the FDA, but are not quite approved yet because they need to be used in more patients. And it gives someone opportunity to be treated with something that they may otherwise not have. And for a lot of our patients, and even though we've got that huge list, they've gone through almost the whole list. And very often they have very little choice left as to what to do. And this can give them an opportunity independent of their race and background. But that has to be built on that fabric of trust. I know our time is going quickly, but I wanted you to, you mentioned so beautifully earlier the Griffin study and how it's making you scratch your head a little bit to say, remarkably, how much better African-American patients did with that quadruplet versus that triplet. Are you doing other studies or studies like that to further understand if the biology in African-Americans is different, such that there are certain combinations that we can give them that would give them an even better response?
That's a great question, Joe. I think we're looking specifically in the relapse refractory setting as well. So purely I'll give you an example of all the enrollments in terms of the CAR-Ts that we had. There was very interesting data purely from an immune perspective that we're seeing. The rates of the toxicities in terms of the cytokine release syndromes, the rates of the neurotoxicity are much lesser in the African American patients, and the efficacy is much higher. So we probably have treated around 60 patients at Emory with the CAR-Ts for myeloma in various trials. And this is a common theme that we see, and we put our preliminary results as a publication purely to say this is an area that needs much exploration. And if it comes to the access to care as an issue, when we look at the 60 patients, 40% of these patients are African American, so which is giving us a good sample size to compare to see so we are seeing the first step to understand is, are there differences existing? And we are seeing the differences.
That's impressive. I mean, to think on both sides. So for those who may not be familiar, CAR T cell therapy, as you described earlier, is where we literally take T cells or immune cells out of a patient, manufacture them and play with them in the lab so that they are basically trained to attack their tumor. Then we give them back to them. I know this is not an episode of Star Trek. Like, this is really what we do. It's just the most amazing thing. And it can be very effective. But part of the problem is we give those T cells back, the body can react to it and develop this immune reaction, this thing we call cytokine release syndrome. So if I'm hearing you correctly, you're telling me that it appears, I know the numbers are small, that in African-American patients, that this process is working better than in Caucasians, and they have less of that negative immune reaction that we don't like to see, less of that cytokine release syndrome. I mean, that could be very important. You know, I talk about the 3 Ts, the access to the 3 Ts, the triplets, transplants, and trials. I got to add a fourth T now and talk our T cell therapy, because it appears from your work that this is something that's very important. I think we all believe in the myeloma community that CAR T cell therapy is going to have a profound impact. But thank you for doing that kind of work. And I'm sure you're going to be following up with more and more to understand it better, because this could really have a big impact in myeloma and within the African American community.
Thank you, Joe. I think we're doing the biological correlations of why exactly this is happening, and that is actively what we're trying to do now.
Yeah, and you have one of the most sophisticated labs in the world when it comes to looking at the biological connection. So I think that's wonderful. Hopefully, we've given people just a little tip of the iceberg of the kind of work and research that Dr. Nooka and his team do, that I think can really have an impact in myeloma overall. You all have had such an impact in the whole myeloma community, but specifically within the African American community. Unfortunately, our time is going really quick, but I just really want to thank you. You know, the percent and just sheer number of patients of African American heritage in whom you've placed on clinical trials in your institution is a testimony to your team and your group, and how hard you work in this. And it really means a lot to all of us, and we learn a lot from you. So thank you so much.